Hello, and welcome to AgeWise Health. I'm your host, Maggie Jess, Director of Nursing at Ameristaff Nursing Services. On today's show, we're going to talk about orthopedic surgery, specifically joint replacements. My guest today is Dr. Bill Ward. Hello, Dr. Ward.
Hello, and thank you for having me.
Thank you for joining us. So at the beginning of every show, we kind of like to get a little background about our guest. So if you could tell me a little bit about yourself and kind of how you ended up becoming an orthopedic surgeon.
Sure. I grew up in the Detroit area, went to U of D high school. Out of high school, I got into the Iniflex program, which is a 6-year medical program. It only had a 30-year grant, so it's no longer in existence, but you do 2 years of undergrad and then you start medical school. After graduating from medical school in '79, I then did my residency at the University of Michigan. And it was interesting. I wasn't really quite sure what I was going to go into. And then I did my orthopedic month as a senior student, and I loved it. It was taking care of the walking well, and you got to see the results of your work darn near right away. The arm was broken and crooked, and now it's straight, and the young baseball player's happy. The person comes in and can't walk, and you replace their hip, and you see them back in the clinic 2 weeks later, and they're pain-free and walking very well. So it was sort of made for me. And so that's why I went into orthopedics.
Wow. I mean, it must be very satisfying to get that gratification to be able to walk well, you said?
Sure, without a limp, and be able to maintain your activity level and your youthfulness. I loved it, and I still love it, although I've been retired now for 4 years.
Oh, okay. So why did you decide to retire?
Boy, that's sort of a complex question. I think it was sort of manyfold. Probably the first and most important factor was my mom had died at 63 and my brother at 57, and he was only a year older. And so I wasn't quite sure how much time I had on this earth. So that was part of it. The other part was the number of surgeries that I was doing in a day was taking a lot out of me. I developed a little heart issue, atrial fibrillation, and medicine was changing a little bit. Everybody had a PA. There were electronic medical records, and I wasn't a computer whiz. In fact, I was more a computer idiot. So I struggled with that. And I realized that I enjoyed being with the patients, and I enjoyed talking to them. And the way things were changing and staring at a computer screen, I wasn't enjoying it as much. Mm-hmm. That and the fact I wanted to spend more time with my family and my wife. And my wife would probably say my golf game too, but in any event, I read several books on retirement, and probably the most pertinent question that one of the books asked was, had you accomplished everything in your occupational life that you wanted to accomplish? And I had. So I felt that I was ready. So I retired.
Wonderful. I think a lot of people would praise you for that. You looked deep inside and kind of figured out, this is what's best for me in my life.
Yeah, and this isn't a dress rehearsal, so
Right.
so you only get one shot at it, and I had enough hobbies to keep me busy, and the wake doesn't drive the boat, so you look forward and you do the things that you enjoy doing.
Good.
So
It's wonderful.
So that's where I'm at now.
Okay. So throughout the years, you practiced for roughly 40 years?
I was in private practice for 35 years.
35 years.
If you count the residency, it's 40 years.
Mm-hmm.
But 35 years of private practice. I practiced at St. Joe's in Pontiac, Trinity Health Oakland, I think it's
Yes.
called
Yep.
today. But I loved it there, and it was a great move for me.
Yeah, I worked there for about 4.5 years, and I thought it was a wonderful system. I would
It
agree with
is,
you
and
on that.
the thing that I probably miss the most is the people that I worked with, the nurses and the surgical techs. They are really the foot soldiers of medicine. I owe a debt of gratitude to every one of them.
That's wonderful to hear. Very nice. So throughout that 35 years of private practice, how has orthopedic surgery, joint replacement changed? What have you seen? What are some of the major changes?
Well, I think the biggest change in orthopedic, that is total hip and total knee replacements, over the years has been the technology. The technology that we have now, or at least as of 4 years ago, is so much more exacting than it ever was when I first started. In fact, one of my professors used to say when we were doing a total knee back in 1984, well, Bill, we got two sizes. We got too big and too small. So now there are so many sizes, and the instrumentation that you make the bony cuts with is so much better. So the technology has gotten better. In total hip surgery, the polyethylene liner that used to wear out after perhaps 10 years of big time wear, now in essence never wears out. The stems that we put in get bony ingrowth relatively easily because it's a better fit, because we have better tools to put them in. So if somebody has a total hip done and it's done well, and they're 50, you can sort of tell them that there's a good chance it will last the rest of their life, barring infection. So the technology changed sort of everything. It made people surgical candidates sooner from a hip perspective, a little bit sooner from a knee perspective, but technology was probably the biggest change. Electronic medical records was a huge change, and wasn't popular with me, as I've already explained.
Right.
I think we used to keep people 5 or 6 days in the hospital after a knee or hip, and now most are done either as an outpatient or an overnight stay, depending on the patient's health. So those have been sort of the major changes.
So for those of us that have always heard, a knee can last 10 to 15 years, that's kind of out the window now.
Well, the polyethylene liner with excessive wear may start to show some wear at that time, but exchanging a liner is done as an outpatient, and it's a 2-week recovery. So you're not taking out the components. You're just popping out a liner and putting a new liner in, and the surgical procedure takes 20 minutes. So it's not maybe a half hour. And the recovery is very, very quick. So it's not uncommon for a knee with maybe one liner exchange to last somebody's whole life. But there are some that do get loose in 5 to 10 years, and we're never quite sure why, but
It can
that
happen.
happens.
Yeah, so that's good information for someone who's waiting. If I only have 15 years, why don't I wait till I'm 65 or 70 to get a knee? We don't have to wait any longer.
No, you really don't. I think the key thing in waiting or not waiting is, can you maintain your vitality? Can you keep your strength up? Can you get your heart rate up? Because if you wait an extended period of time and your body, not your age is going to get, your chronological age is going to change slowly, but you don't want your physiological age, that is all your muscle tone and your flexibility, you don't want to lose all that, then expect to recover like somebody who didn't wait. So whatever a person is doing, or making a decision to pull the trigger or not pull the trigger, as long as you can maintain your vitality, your strength, get your heart rate up through swimming or biking or things that don't hurt your joint the next day so you can be active again the next day, then you should wait. And if you can't be active, you probably should pull the trigger sooner rather than later.
So what's a good candidate for a joint replacement versus someone that you wouldn't operate on? How do you kind of figure that out?
Well, I think that, first of all, general health is the most important component of deciding whether somebody's a candidate. You have to be healthy enough to withstand a major procedure. And if there is a complication, like an infection or a blood clot, you have to have the body, your body has to be able to recover from a severe insult. So general health is the most important factor in being a candidate. Some people would say wait. I think as long as someone's weight is close, they will do better afterward with a joint replacement because they can be active. Mm-hmm. Although one of my favorite lines is, even with activity, you can't outrun your fork. So it's sort of important that people have a reasonable body habitus, mm-hmm. because the risk of infection goes up as one's body mass index goes up. So and there are certain numbers that your orthopedic surgeon will toss out. So you need to be appropriate, mm-hmm. From a weight perspective. People do better when they're active before and they haven't fallen into a weakened state, because surgery always makes you sicker before it makes you better, and you want to be able to recover, and you don't want to have a large distance to recover from waiting and becoming atrophied and weak, and not be the person that you otherwise should be. So staying in good shape before you have surgery is important.
Yeah. Are there certain exercises one can do before their surgery, whether they were active or not? Could that help?
Every orthopedic office who does joint replacement will pass out an exercise program, okay, prior to surgery. I would always give it to people 2 or 3 years before. You should start doing this. Don't let it, I'm going to give it to you, don't let it just collect dust on your nightstand. You should start doing this now, especially if you're going to put off joint replacement. So every office will give them those exercises, but exercises that you should do are really those that don't hurt you and stop you from exercising the next day. Arthritis, really, once you get warmed up, it starts to feel better. It's if you overdo it the next day that you can't get out of bed, and then you can't exercise that day. So you want to do things like ride a stationary bike, swim, do things that won't bother you. But impact loading, pounding on your knee or your hip, is like knocking your head against the wall. Sooner or later, don't complain to me about having a headache. So, you really want to do things that don't affect you the next day.
Okay. Yeah. So now, post-surgery, is there anything you have to avoid after joint replacement?
Well, I think you sort of break that into the total hip patient, and the total knee patient. The total hip patient, in the first 3 months, needs to be somewhat aware of extremes of motion, extreme flexion and turning their hip in as if you're crossing your leg, the affected leg over the other leg. If you've had a posterolateral approach, a standard approach from the back, if you've had a direct anterior approach, you don't want to put your leg into extension, in other words, your hip way behind you, and externally rotate it. So you have some limitations of motion. probably the most important thing is you don't want to do any twisting exercises like golf for 6 weeks, despite
Okay.
the fact that you feel great. That has nothing to do with it. You want the bone to grow into the stem, and then it's permanent. If it wiggles around a little bit, develops a little scar tissue, and never grows in, you're either going to end up with a revision or a hip that hurts you, and you have some anterior thigh pain for the rest of your life. So 6 weeks of no torsional exercises, but walking straight ahead without a limp, that is to say, keeping your head in the middle when you walk. Everybody with a bad hip shifts their head to the affected side and comes back. That's how they walk. And so your family can tell you when you're walking appropriately after you've had a hip replacement by just seeing if you keep your head in the middle when you're doing your heel-toe gait.
Okay.
So that would be a total hip. With a total knee, you just have to work like heck in the first month to get your knee motion back. It's gonna hurt. And people say, well, how do I know a good hurt from a bad hurt? Let me tell you, get your knee straight and get it to bend. And I don't care how much it hurts, because that's what you need to do. And a total knee is 3 or 4 times more difficult to recover from than is a total hip. The hip is a more forgiving joint. It's easier to recover from. It's a ball and socket. The knee requires extraordinary effort on the part of the patient.
Okay. I've seen that. And I've dealt with a lot of patients and a lot of family members that have a lot of knee pain. And they have said that. And after their total knee, and I'd say about a good 3 months, they're like, I'm not in pain anymore.
Yeah,
But they had to go through it.
It's one of the most, those 2 procedures are some of the most rewarding in orthopedics. And there's nothing like a happy patient.
Yeah, that's so true. In your experience in the last 35, 40 years, what types of patients do the best in joint replacement?
Well, the type A personality that is a little bit competitive, has a pretty high pain tolerance, and can follow a few simple directions. Really, you just need somebody who is willing to play by the rules, and they do great. And that's barring weight or previous athletic accomplishments or anything. It's just you just have to attack your recovery with really vim and vigor, and then you're going to do well.
Okay. So big take homes are discipline and listen.
Correct.
Yeah? Okay.
And ask the right questions and get the right answers from your doctor or his PA or nurse practitioner.
Okay. We're going to shift gears now and talk about a little bit about post-surgery and physical therapy. So is physical therapy different for a hip than it is for a knee?
Physical therapy is absolutely mandatory for knee replacement surgery.
Okay.
It's harder, it's longer, and you probably do need a bit of a cheerleader and coach. So physical therapy for the total knee replacement patient is mandatory. For a hip replacement, some hip replacement patients can simply do their exercises. They come in walking well, and they may or may not need to do supervised therapy, although most doctors will give them a slip for a month. But a lot of them, by the time they get 3 or 4 weeks out, are doing great and want to come in and stop therapy and move on with life with the restriction of no torsional activities for 6 weeks.
Okay. What is atrophy? I've heard that before when we deal with muscles and joint replacements and things like that. And how can you avoid it?
Well, life as a muscle is very simply put. If you don't use it, you lose it. So atrophy is the loss of muscle mass. And it's very difficult in the over 60 population to build muscle back, which is why right after surgery, you start, and even before surgery, you start trying to build muscle, because Surgery always makes you sicker before it makes you better. You're going to develop some atrophy because of your relative disuse, but the moment your pain level allows it, you need to step on the gas and build some muscle. And you need to do it even before surgery. So,
Okay. So for hips, you were kind of saying, next day you should be up and walking, right?
or that we get them up in the
Post-op?
right away, and if they're doing okay, they can go home.
Okay.
So it's all sort of driven by how the patient and
Okay.
their general health responds to the insult of surgery.
Okay. What's the average recuperation for a hip versus a knee
Well,
on an average person?
I would say most hip patients at 6 weeks, you have to almost hold them back from activity. And most knee patients are just beginning to start to see the light at the end of the tunnel. So most hip patients are walking long distances at 4 to 6 weeks, and most knee patients are not doing that for 6 to 8 weeks. So I think the difference is probably a month between the two.
Okay. And within your years of practice, what are some common complications that you've seen?
Oh gosh, well, the worst two potential complications in either a total hip or a total knee would be infection or deep vein thrombosis, a blood clot. So blood clots can kill people. Unrecognized, when they don't kill you, sometimes they can result in chronic swelling of your leg. Infection is very difficult to be treated. Sometimes early can be treated with a washout, but late, the prosthesis has to be removed, an antibiotic spacer block put in, and then a new prosthesis put back in 8 weeks or so later, or whenever the numbers come down that shows the eradication of your infection. So those are the two most dreaded complications. Knee replacement, I would say stiffness is a complication, and that's why the patient has to work really hard. The surgery has to be done very meticulously. So stiffness is a potential complication, generally remedied by a manipulation, and then go hard at physical therapy once again so that you don't end up in the same situation. The other potential complication with the hip is dislocation, and that's from either A, malposition of the components, or B, the patient not following the rules.
Did the torsion, did something?
Well, they put their hip in a bad position in the early recovery phase.
Okay.
Either flexing it way up and turning it way in, or moving it way back and turning it out, depending on which approach was used for their surgery.
Throughout your years, do you have any extraordinary examples you can share with us?
Well, I guess thinking about other orthopedic surgeons out there, I would prefer not to talk about the outliers, because I can tell you in my practice, yes, I had outliers, guys that did so great. I would tell them, when you're in the waiting room, please don't tell people when you had your surgery and demonstrate how well you're doing, because it's not reproducible. So everybody gets those guys. I would say probably my best example of an extraordinary patient was a gentleman who I did his knee replacement when he was 45. Way early, but he had a crooked leg and he couldn't walk. And he needed to work for a few more years before he could retire. And then he retired up in Gladwin, Michigan. Why I remember this, I don't know. But just before I retired, maybe a year before I retired, he was in the waiting room. I saw him out there, and I'm thinking, his knee's loose. Something's wrong, And here he came in to have his other knee done. And I guess I would say, to see somebody back 30 years later or so with his knee that I did, and the first 5 or 7 years are really tough because it's sort of like giving your car to a 17-year-old, the first 3 years, he's going to drive the heck out of it. Well,
Yeah.
that's what this guy did, but his knee lasted. And I would say that would be a great example of an outlier. I don't know why he did so well for so long, but the fact that he drove down to have his other knee done was exceptional and was really rewarding for me.
Mm-hmm. It says something about you too, sir, so that's wonderful.
Thanks.
For those watching and thinking, geez, I'm in pain, but I can kind of live with it, and they're kind of waxing and waiting on this decision, what advice would you give them?
Don't decrease your activity and lose your vitality. Every single person that has their knee or hip done goes through a period of denial. Oh, it's not that bad. Oh, I can live with it. As their muscles melt away, their general physical health melts away, and then expect to do as well as the person who didn't wait. So I would say be really active, and when you can't be active anymore and you start to feel like you're losing your strength and your vitality, pull the trigger, because you will be better and you will be happy about it, and wonder why you waited. So that would be my advice.
Okay. What do you think the future holds for joint replacement? What do you foresee happening?
I think in the near future, things like the robotic surgery and virtual reality are going to make the surgery a little bit easier. But it still takes the meticulous surgeon who, in a knee, is able to perfectly balance the ligamentous complexes about the knee. So I think it's still going to be predicated upon having a really great surgeon do your procedure. I think the distant future, there will be some sort of drastic change in cartilage metabolism and research on what keeps your articular cartilage alive and stops it from deteriorating. I think that's the future of really what is going to happen to orthopedics. Someday, just like with cancer, they're going to say someday, gee, they thought they could cut it out. How barbaric. Someday they're going to say, well, we just injected this enzyme or this DNA or whatever into a joint, and it will be cured or will start on its way to being cured. I think that is the future of orthopedics, probably 50 years from now, but that would be my hope, rather than replacing it with metal and plastic like we are now.
Okay. All right, great. Is there anything else you'd like to share with us today?
Probably about the only thing for the young people who might be watching, being somebody's doctor is an honor. It is the greatest job known to man. People trust you with their life. I think, I would tell young people who think about being a doctor to go for it, because you'll never regret it.
Great. Well, thank you so much for being on our
You're
show
very
today,
welcome.
Dr.
It
Ward.
was an honor.
It was a pleasure. Thank you, everyone, for tuning in today on AgeWise Health. I'm your host, Maggie Jess. If you have any questions about today's show, please feel free to call 248-288-2270. Stay safe and healthy.